Now, one aspect which really hasn't been covered that much is restorative space. And as a prosthodontist, I need to know how much space do I need to satisfy the requirements of aesthetics, mechanics, and biomechanical integrity. When we talk about immediate loading of full arch restoration via a graftless approach, we have protocols which have been set up for tilted implant placement. We've been told what type of multi-unit abutments we should be using. We've talked about primary stability, we've talked about torquing, but we really don't have much information on what should the dimension of our prosthesis be? What should the undersurface of the prosthesis be so that we can cleanse that restoration appropriately? Now, the good news is that we've been working very closely with Nobel Biocare over the last several months to develop protocols which will make this aspect of care much more efficient and much more predictable. Now, what you see on the screen are the common errors we see in the immediate transitional prosthesis. And for the purpose of this presentation, I'm going to be focusing on the implant-supported fixed denture, or the hybrid, as some of you may know it. Now, these are the common pitfalls we see. And in most situations, they're a result of inadequate bone reduction. And as dentists, we're trained really to keep teeth, and we're trained to keep bone, right? But as a restorative dentist, when I don't get enough bone reduced, it really gives me it provides a tough time for me to provide an appropriate restoration to the patient. If we don't have enough bone reduction, we can get a poor emergence profile. Here you see there's too shallow an implant placement when we're considering the ideal incisal edge position, and we end up having a horizontal shelf. Now, this horizontal shelf can be food entrapment, can be very uncomfortable for the patient, and also aesthetically, the lip caves in this area. We can have concave tissue contours. When you see this on the screen, look at that plaque development there. I remember a paper from 1966 Sheldon Stein wrote about residual pontic contours. How is the patient able to clean underneath this type of restoration? We sometimes can get short, unaesthetic teeth. And after months of therapy and thousands of dollars later, it becomes very disappointing for the patient to walk away from the office with a restoration like that. And finally, we get food entrapment. And food entrapment results from inappropriate contact between the restoration and the tissue. So today, what we're going to try and focus on are 4 main key parameters. Essentially, what we're going to be talking about is how much restorative space do we need? How do we determine that amount of restorative space? And in most of these situations, we require bone reduction. How do we communicate this bone reduction to our surgical colleagues? So we first start with the tooth position, the position of the maxillary incisal edge. Dr. Sheesh so eloquently put it that every rehabilitation, whether it be tooth-supported or implant-supported, starts with the maxillary incisal edge. I'm not going to spend too much time on this particular subject in front of such an esteemed audience. I will just say that when the patient is in repose or in the F position, the maxillary incisal edge should touch the wet and dry line of the lower lip. As clinicians, we need to be detectives. Often patients that present to us with a terminally failing dentition have lost a lot of posterior teeth. And in a majority of situations, we diagnose them as having lack of posterior support. And when the patient presents with lack of posterior support, we get occlusion on the front teeth, flaring of the front teeth, and over-eruption. And in more cases than none, the anterior teeth are often over-erupted. Now, if you look at these 2 pictures over here, the slide to your right, I'm sure most of you would agree with me that the maxillary incisal edge is not in the correct position. Now, it's our responsibility to reposition it. And when we reposition it, that impacts the implant placement, and it also impacts where the bone needs to be reduced, because we need to have an adequate transition space for that restoration. Restorative space analysis is key. Depending on the type of restoration that the patient requires, whether it be fixed implant crown and bridge work or an implant-supported overdenture, Each type of restoration has unique dimensional tolerances for restorative material. We need to have sufficient space for restorative material to make it last a long time. For the fixed implant supported denture, a minimum space requirement would be 16 millimeters. And for 16 millimeters, we need space for the titanium framework, the acrylic resin, and the tooth itself. Now, what happens when we compromise on this space? We're going to have fracture of the tooth, maybe fracture of the acrylic, and in extreme circumstances, even fracture of the titanium framework. Now, with space, when we have enough space, we're able to develop an appropriate emergence, appropriate contours, and even appropriate aesthetics. Dr. Marlowe, in his first case, showed a patient with a gummy smile, excessive gingival display, and how difficult they are to treat. And from a diagnostic perspective, there's two things we have to look at. We have to look at ridge display and lip length. When the patient is edentulous and the patient smiles, that soft tissue should not be visible. If that soft tissue is not visible, the transition line is hidden. And when the transition line is hidden, we have some flexibility in terms of restoration color, contour changes, and shadows. And it truly results in a much more aesthetically pleasing appearance. Now let's take this example. This patient comes in, smiles, and the entire ridge is visible. And despite our best efforts, even if we have some of the best surgeons in the world place implants in this situation, the horizontal transition line will be visible if you are planning for a fixed implant supported denture. This patient may be more of a candidate for fixed crown and bridge work rather than a fixed implant supported denture. And we can use some of the best ceramics in the world and do some exquisite restorations, but if this transition zone is visible, it will not result in a successful outcome. Now, as well as aesthetics, we also need to look at contour changes and how the emergence profile of the restoration should be. Take this example. Say we place the implant in that position, and our ideal incisal edge position is in a class 1 relationship with the opposing dentition. If we try to transition that restoration, we end up having a horizontal shelf. Okay, and as I mentioned earlier, this horizontal shelf really is for food entrapment. It really causes a problem for a patient maintaining hygiene. The only one reason I can say that this horizontal shelf is a good thing is if the patient keeps their mouth open long enough, you may see like pigeons fly in and start perching on this horizontal shelf. That's about it. What do we need to do with this type of situation? We have to be able to do some bone reduction. We have to be able to place the implant a little bit higher. And we have to be able to change the contours of our restoration. And when we have contours such as this, the patient is able to clean and maintain that restoration well. So we've looked at lip length and smile line and the impact they have on restorative space, emergence profile, and aesthetics. So the last thing we really need to look at is appropriate tissue contact. Now, why do we need appropriate tissue contact? We want to avoid food entrapment. We want to make sure that the patient has cleansable contours. They can get underneath that prosthesis and clean it well. We want to be able to eliminate that airflow from underneath that restoration so that the patient's speech is appropriate. And this being a provisional restoration, like with any other provisional restoration, we're using it to develop the final tissue contours. When we're fabricating that provision, when we're fabricating that transitional restoration, very important that we have a convex undersurface. It's highly polished, and over a period of time, we utilize it to compress the tissue so that we have a concave tissue surface and a convex restoration surface. And it makes it much more conducive to keeping it clean. So we've talked about these restorative parameters, and most of these requirements really require the surgeon to be able to reduce enough bone for the restorative dentist so that we can achieve all of this. So let's talk a little bit about bone reduction guides and how we can communicate this bone reduction to our surgeon. Now, there are many techniques in the literature for bone reduction, and the requirements of a bone reduction guide is that it has to be stable, it has to be easy to use, and there has to be a reference point from which our surgical colleagues can measure. For a dentureless patients, it's relatively straightforward. We can make a duplicate denture, and essentially, there's a technique called the window technique, whereby we make a window 6 millimeters from the free gingival margin of the denture, and the surgeon scores the bone in that area, and when they open the flap, they reduce the bone to give us enough restorative space. Now, sometimes our surgical colleagues are not provided with these reduction guides, and they essentially ask the patient to smile very high, and they reduce the bone 5 millimeters above the highest smile line to be able to give us sufficient reduction. But how do we communicate space in the patient when we have treatment planned to remove all the teeth and provide them with a fixed implant-supported denture in both the maxillary and the mandibular arch? Now, if you look at this patient from gingival margin to gingival margin, we have 23 millimeters of space. Based on our previous discussions, we need 32 millimeters of space for all components for the restorative materials. As Stephen Covey said, we have to begin with the end in mind. We have to visualize where we're going and make a plan on how we're going to get there. Okay, so on your left-hand side, you see what I want to do. This is the amount of restorative space that I need. So what we do is we make impressions, we fabricate diagnostic casts, we cross-mount a duplicate set of casts, and essentially we mark our horizontal and vertical reference lines, and we also mark exactly how much bone reduction that we need. We then remove the teeth, mark the gingival margin positions, and then we go ahead and we start setting up our tooth outline. We set the maxillary anterior teeth, and here you can see we've kept the posterior teeth because the posterior teeth will serve as a reference onto which the surgeon will place the guide and be able to have a reference point from which to do the bone reduction. So the maxillary anterior teeth are set up. We duplicate that in clear acrylic resin, and then we remove the flange area. So now we have our definitive incisal edge position. We have a gingival margin from which the surgeon will be able to measure, and hopefully this, at the time of surgery, will become very, very predictable. So let's go to the surgery. The anterior teeth are removed. You'll see the posterior teeth are kept as a vertical reference, and the surgeon can actually place this on the teeth, and it can be very, very stable. The surgeon then just goes ahead and makes measurements with the periodontal probe just to ensure that we have enough space, and if we don't have enough space, bone reduction is performed prior to our implant placement. And with that, we're able to achieve what we had imagined. We're able to achieve a restoration with appropriate contours, emergence, and tissue surface. I hope in these last 10, 12 minutes I've given you enough, some information that you can go back to your practices and use. Before I finish,